lens are, the rare type when the astigmatism is up to 5 or 6. Situation could be the mark is difficult, and we all know that the 10-degree shift of the axis decreases the efficiency of the desired cylinder correction by more than 30%. And the other fact also remains that there is a cyclotron deviation up to 2.6 plus minus 2 degrees. It is anti-clockwise in the right eye and a clockwise in the left eye. Now the situation is, if the mark is gone, what do you do? And the trick is, don't do anything. Just put a little bit of Pipangul and that will take care. Look at this patient. He will not let you do anything. And his astigmatism is 5 cylinder. What do we do? This is a trap. The other situation, the moment you come out, the AC collapses. And the lens is liable to tilt and rotate. Even while removing the speculum, the AC may collapse and the lens might rotate. The other trap is, suppose it happens, you have lost the very atypical corneal astigmatism, then what do? The patient has waited for 5 days for the lens to come and it has dropped. So these are the traps. What I did in second case was when the patient was very uncooperative. Doesn't matter. Give it peribulba. Measure the 90 degree on the table, whatever it is. Because as I said, the literature says that the cyclotron to 4 degree or to 5 degree at the max. So it doesn't matter. The patient has got a 5 cylinder. So if you are wrong by even 10 degree, you are achieving at least 70 degrees. And in the last case when I dropped the lens, there was so much pressure that we picked up the lens, washed it, and put in the eye of the eye. Put the lens in the eye. I do not advocate this, but this is a trap. I couldn't help it. There was so much of pressure, and we have a very good quality control in our operating theatre. The floors are cultural certificate test is done of the floor, of the air, of the table, of the laminate, everything. So we were very sure that nothing is going to happen. And thank God, nothing happened. The patient is doing well.
You want to recommend this?
I said I do not recommend this.
Girish, can you comment on it? I think everything is wrong with it.
No, I said I do not. No. My first sentence was I do not recommend it. This is a trap.
No. Girish, can you comment on it?
I wish better to wait for and put the lens on the next day or after 2 or 3 days.
There was so much pressure. The patient had already waited for 5 days. It was getting irritated because in our practice, what we do is we operate the very next day, and the patient is so irritated.
For this pressure, you should have a toilet around. You should not put this lens in. What was your second trap?
The patient was very, very uncooperative and will not let you do the marking. And the center was 5 degrees.
I have always wondered, Girish, please comment on it. Most of us are trying to correct the astigmatism by toric IOL and not resorting to the corneal measures to place the incision, corneal incision in that steep meridian. or for that matter astigmatic keratotomy, or for that matter Alzheimer laser, LASIK keratotomy?
Yes. There are two things, and when we are correcting the astigmatism, at least we should not correct if it is less than 1.5. That's one thing. I usually do the dual incision on the two sides, and second thing is since toric is introduced, I have always used a sentence that the toric science is a incomplete science. It is not a complete science yet. We are treating the astigmatism at a level of a lens, and astigmatism is at the level of a cornea. So the distance between the two, and there are two cylinders which are neutralizing each other at a different level, that creates an aberration, and that aberration is a coma. So due to this, there is definitely we are not getting a perfect clarity or an aberration-free optics of the eye. So if the astigmatism is very high, I think it's better to go for a LASIK, post-LASIK, rather than to treat around the toric lenses. And especially in a patient, if you are having a toric and multifocal, and if you are promising a good result to the patient, then it's better to go for a LASIK after that. That's another option we have.
My patient had a little bit of corneal opacity, and that is what it created. It created a very high astigmatism. And since we had to operate for the cataract, we thought to correct it.
Yeah. I have noticed
the astigmatism with the corneal opacity is always irregular.
Yeah.
In this case, it's all right. Every time it was coming to the same direction.
Sir, can I add one thing?
Please.
I have only done 7 cases till now. If you are in doubt that you have to go for a toric lens in this patient or not, especially the corneal opacity and irregular astigmatism. So, suppose the patient has a keratoconus, you have removed the cataract and you are not deciding about the axis.
Sir, we absolutely exclude the irregular.
Yeah, that's what I'm telling you. Just let me finish. In these 7 cases, what I have done is I made the patient effective on Monday, and next Monday I implanted the lens in a patient in which axis the patient is accepting the glasses. So you make this in 2 stages. Remove the cataract on 1 week, and next week you put the implant, that is the toric IOL, on a next week as per the acceptance of the glasses of the patient. So I have done only 7 cases, and this works at least good in some cases whether we are in doubt about the degree and astigmatism.
Will you allow the usage of 1 diopter less or more lens which is available? With that please, okay, a good answer. You have lost the lens outside. Instead of getting another one or using the same one, if you use a...
To conclude, my conclusion was, this is a trap, and when you have a very atypical cylinder, you must have another pair with you.
No,
One
thing is certain, you can't put that lens.
You should not put that lens.
No, question is, you will embarrass and you should not put the lens.
But I do accept what I've done, because I was so sure of my quality control that there is no problem, because we keep on doing even then I could not have done it.
Okay. Can I have the lights here?